Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
For attending, and I hope you guys are going to find this helpful. And if you have any question, please stop me or ask Dr. Yuva, or because I don't see the chat, so you can just stop me or ask the doc. All right, so in the beginning, I'm from Saudi Arabia, as Dr. Yuva said. I'm currently in Riyadh city, which is my city where I was raised. It's in the Middle East. And here's a couple of photos of Riyadh at night. And I hope one day we'll see you guys visiting us. I attended King Saud University in 2005, and then I earned my dental degree in 2012 from the same school. This is our new building. It was launched probably 3 years ago. It's 11-story dental hospital where every floor is representing a specialty it's fully equipped to support that specialty. In 2014, we flew to Chicago to pursue my postgrad studies in prosthodontics, where I went to University of Illinois at Chicago. In 2018, I graduated from the school with advanced training in prosthodontics with master's in oral sciences. And then I moved to California, where I joined Loma Linda University for 1 year implant fellowship from 2018 to 2020. So let's go ahead and start. And according to the American Association of Oral Maxillofacial Surgeons, that almost 70% of adults aged from 35 to 44 years old, at least missing one tooth. And then 25% of 75 years or older missing all their teeth in one or both jaws. And according to American Academy of Implant Dentistry, 3 million Americans having implants, and this number is growing by 500,000 a year. So we know tooth loss is a common problem, and therefore the use of a dental implant also is a common practice. And as a prosthodontist or restorative dentist, we are faced with a difficult task to restore and establish beautiful smiles, as well as establish the occlusion. And one of the most difficult situations we face in daily practice is replacing missing single anterior tooth. And this dental implant enabled us to do that. Also, implants enable us to restore the occlusion and function without having further damage to the adjacent teeth or having removable prosthesis, as you can see here. As we know, in 1969, Professor Pranemark introduced to us the implant by having the orthopedic surgery, the famous surgery. Well, he found that the bone was incorporated between the titanium, or the titanium surface actually was incorporated by the bone. And since then, titanium was considered to be the gold standard for dental implants. And this is because of its easy to manufacture, it's a good mechanical properties, and the resistance to corrosion, and the high biocompatibility this alloy or this material exhibited. And as you can see from this schematic, that the main differences between the tooth and the implant probably direction of the gingival fibers from having them to be perpendicular to the tooth, to be parallel to the implant from the tissue to the bone. And this is important to know and to understand as we go further now. So we know dental implant is not really as easy as just taking the tooth out and restoring it with an implant and maybe with 2-piece or 1-piece crown. It's in every different clinical situation we are faced with dental implants. We have different options and scenarios to restore that implant. It's not as easy as just taking the tooth out, placing an implant, and restoring it with the crown. So what are the options that are available to restore an implant in a different situation? Just like, for instance, an anterior or posterior implant, or implant that is ankulated or more straight. We categorize them according to the method of retention, if it's cemented or screwed, and the type of material we have, if it's gold or porcelain or zirconium or a hybrid or mix of all that materials. So when it comes to method of retentions, the three major designs we have now in dentistry is either the screw retained prosthesis that comes, the crown is and the abutment in one piece, or we have it cemented on an abutment, which is the crown and abutments, two pieces, you deliver them in the patient mouth, or what we call by screw cementable or screw mentables, or the what do they call it, combined prosthesis, which is an abutment and then a screw access through the crown, and then you either cement it in the patient mouth or outside the patient mouth, and then you deliver it. And there's different indications for that. So what really drive us to design or to choose one over the other one in terms of retention? There's different options or different scenarios that we are facing. So the thought of process that drive you to choose which one over the other one is looking at the ease of fabrication. Can you make that chair side in your office? Or how much the lab will charge you, for instance? And how fast can you make that prosthesis? And then in terms of aesthetic, in terms of where's the screw access coming from? When we look aesthetically in the interior area, can I make a screw retained, or should I make a cement retained to hide that screw access? In terms of framework passivity, if we have angled implants and you cannot really have like a full arch framework that sit or fit passively, then sometimes you will have to correct the angulation by an abutment and then use a cement retain, or maybe use a screw retain as well. And in terms of the restorative space that you have in that situation, let's say you are faced with a short clinical crown, can you make a cement retain? Cement retain will need an abutment, as we said, and a crown. And that abutment have minimum height, maybe 3 to 4 millimeters, and then the crown need 2 to 3 millimeters sometimes. Thickness, so that's add up to 7 millimeters. What if you have only 4 millimeters? Then you will be faced to make maybe a screw retain, a gold screw retain implant crown. And then in terms of retrievability, of course, we know screw retain is easy to, you can access that screw and retrieve it and then fix whatever problem is, and then you can put it back again. But when we look at the cement retain, you will have to section the crown. It's hard to retrieve. And then in terms of occlusion and occlusal design, and where's that screw access coming from, and can you make it a screw or cement retain? So this is just as typical as anything else. We will look at the advantage and disadvantage of each option. When we look at the cement retained option, of course, we can correct any angulation, easier passivity in terms of a full arch prosthesis, or maybe 3 units also with angled implant. And it gives you ideal anatomy because there's no screw access coming from the occlusal or incisional surface, and improving the aesthetic by correcting the angulation. And of course, the major disadvantage of a cement retained restoration is the residual cement that sometimes we cannot detect underneath, because we're using cement to put the crown on top of the abutment. And of course, you will need more restorative space. And then the cost sometimes is more involved, but not always. And of course, one of the major other major drawback is the retrievability, because you have to section the crown if you cannot knock the crown out of the abutment. And when it comes to cement retained, there's 2 major abutments that are available in the markets, which is either the stock or the prefabricated abutments, or we have the custom abutment that is made, customized to the patient tissue or height of the gingival or peri-implant mucosa. So there's the advantage and disadvantage of each, and there's different believers for each. I am used to custom abutment where I can control the design of the abutment to follow the peri-implant mucosa and the biological wood shape But also the prefab or stuck abutment, nowadays they have more options in terms of their height, because they used to have like 3 uh, different heights only, and you can actually control it. But in terms of the thickness of the abutment, I think you can prepare that abutment. So that's a different topic. So here's a clinical situation. This is one of my patients that I saw during my residency, where I placed an implant anteriorly, but that implant was, the screw axis was really going through the midfacial of central incisor. So I had to use a custom abutment. You see that custom abutment is duplicating the tissue contour and height. Here's the tooth. And this is without the crown, with the abutment placed. Here's with it. And then when we look at the screw retain advantage and disadvantages, so we understand the main advantage that there's no cement problem. You don't worry that you're going to leave a cement behind that will develop problems in the future. And then of course the retrievability is much easier. You can just grind that composite or whatever material you use to seal the axis, and then you can retrieve it. And you can also utilize the screw retain crowns when you don't have a lot of sort of space, because it's going to be one piece. And then of course you have one interface between the crown and the abutment. Is usually casted or pressed on the abutment. And then the disadvantage is the axis hole. Of course you will have to hide it or block it. And then I wouldn't say that's a disadvantage, but sometimes you will need to have an ideal implant position so that screw axis won't be going through an aesthetic area. And then the cost as well. And then higher incidence, yes, of course, you will have a higher incidence of a screw loosening compared to cement retain crown, because there's no cement layer that works as a cushion with the forces, masticatory forces. So sometimes the screw will loosen it a bit. So here's an example of a screw retain metal ceramic crowns. It's basically, you will get this. So this was made by burnout abutment, or they call it gold abutment from Nobel, where you buy it from them with a plastic sleeve, and then this plastic sleeve will be waxed up and then burned out, and then you can stack the porcelain on top of it. Here's a clinical scenario. This is one of my patients during residency. I placed an implant there to restore the second premolar. This was an AlResayes implant. And then here's the final restoration. I chose that design because the implant was placed properly, the screw axis going through the occlusal area. And then the patient didn't mind having maybe composite to seal it later on. And it's a one piece. So that's where I chose to have this design. And then when we look at the screw cementable or screw mentable design, or the combined design, where you have an abutment, and this is used with maybe with an Emax or zirconia crown, because we cannot have them made in one piece sometimes with the abutment. So we mill the Emax crown and have the abutment ready, and then the Emax crown will be milled with an axis hole and will be cemented on top of it, instead of having a cement retain Emax on abutment. So the main advantage, of course, like a screw retain, there is no cement problem, because usually you cement it outside the patient mouth. And then the retrievability, because you can just grind that composite or material that you sealed it and then take the crown out. And then different materials available, you can choose, like I said, and lithium disilicates or zirconia crowns, or even metal ceramic crowns. And the main disadvantage, such as in screw retain, that there's an axis hole that you have to hide, and if it's going through the facial, then they have to correct it, or you have to choose something else. And of course, you will need an ideal implant position and extra clinical steps as compared to the other two designs, the cement or screw, because now you have to either cement it outside or then the patient mouth. And of course, two interfaces. So when we look at the reported complications for the implant restorations overall, when we can divide them into technical and biological complications. And the major technical complications that I found in the literature is the loss of retention, that the crown will come out, loosening of the abutment screw, the loss of the screw axis fill material. Those are the three main ones. And then it comes, of course, to the fracture and chipping of the veneering porcelain in terms of metal ceramic or in terms of layered crown with the porcelain. And eventually this problems might lead to future problems such as fracture of the implant abutment or the framework of the screw. And then the major biological complications, of course, we'll see is the bone loss, which is more than 2 millimeters. And then the peri-implant mucositis, peri-implantitis, and then some soft tissue complications such as recession and fistula, and then the loss of the implant eventually. These are the major biological and technical complications that I found in the literature for the implant restoration overall. But when we have a closer look in terms of the performance of the clinical of the implant crowns, such as cement retain over screw retain, this is the major meta-analysis and the papers that I found, that overall there was no significant difference in terms of the performance between the screw retain versus cement retain crowns in terms of the survival or the success. However, when we look at the screw retain tend to have more technical complications, and the cement retain tend to have more biological complications. Although during my reading through the literature, I found that screw retain also have to have more biological complications. And this is not because of cement, it's because that screws become more loose with time, and this loosening get the crown to get some food impactions and irritation to the gingiva or the peri-implant mucosa, and it will lead to biological complications. However, I found this conclusion in one of maybe Dr. Saylor paper, that considering the risk with the cement retention and the limited options to intervene after having problem when we cement, because we'll have to section it, it seems to be appropriate to recommend and try to plan to have a screw retained implant supported restoration. And then here's a few literature or papers that summarizing the problem with the cement retained restoration, and which is mainly because of the cement removal. And then when we look at the type of cement, they found the resin cement is most difficult to remove, and then it will cause scratching to the abutment when we try to remove the extra cement or residual cement underneath. And then clinically also, they found if you have the cement or the junction between the abutment and the crown is 2 millimeters subgingivally, you will have more cement that undetected. So you will not be able to see that cement, and you will think that you cleaned the cement already, but you cannot detect it. And then radiographically, they found, radiographically, they found that most of the cement is difficult to detect if it's less than a millimeter, except for a zinc phosphate. So if you have a less than a millimeter thickness cement that remaining, and it's maybe a resin cement, you will not be able to see it. And this remaining cement might develop a future problems. I don't know why this is not advancing. Hold on. This is what I said also about clinical detection and radiographic detection of the remaining cement. So it's really a major problem. So, okay, let's say you're faced with a situation, you have to use a cement retained implant crown. What is the techniques that to minimize the residual cement remaining? So here's the famous paper by Dr. Wadwani that you duplicate or replicate the abutment before you cement by injecting a BVS inside the crown, and then you will have a replica, and then you add a layer of cement. You remove any extra cement, and then you cement it in the patient mouth. Now you removed all the residual cement extraorally. And then other techniques is to have to cover everything with the Teflon tape, such as the remaining teeth and also the abutment, but sometimes this might interfere with the seating. And then the other technique also by Dr. Wadwani, they did this in vitro where they have different designs in the abutment, and then they made a vent hole, and the vent hole design was the most effective, that leaving less residual cement coming outside the crown. And then, okay, let's say you have fixed the problem of removing extra cement. How about retrievability? If you want to retrieve it in the future, there's one technique that you can make a vacuum formed matrix on top of the crowns before you put in the patient mouth on the cast, and then you can mark. You put it back. You remove the crowns and put that vacuum form on the cast, and then you can mark where the screw is, and then you can leave it in the patient box just in case in the future you need it. Another technique is to stain where the screw axis is coming from, just little staining. The lab can make it for you, such shown here. You have a road, metal road, and a surveyor maybe, and then you find where the screw axis on the abutment, put the crown, and now you know where is it, and you can just add a little stain, and then in the future you can hollow it. Okay, now we have some, we organize our thoughts in terms of the method of retention. And now let's talk about the type of materials available. When I look at the literature, they really talk about there's no major significant difference in terms of you should choose a metal ceramic or should choose a monolithic crown or an Emax monolithic crown. There's really no major difference in terms of survival and success over the years. However, we have to understand the limitation for the lithium disilicate in terms of like 3 units or single crowns. You have to follow manufacturing instructions. So I have a few questions. Is it possible to combine cement and screw? Yes, it is possible, as I showed. Screw cementable design, it can offer you that. I'm not sure if you have other question in terms of that regard. Can subgingival residual cement alone lead to peri-implantitis? Yes, it has been shown. However, this is a big topic too. There's papers that shows a patient with history of peri-implantitis will have more problems in terms of residual cement that will lead to peri-implantitis. And then some papers saying that if the patient has no history of peri-implantitis, may not react to residual cement. So it's a big topic, but definitely residual cement is a major problem for peri-implantitis, peri-mucositis as well, and bone loss. All right, if you have no other questions, now I'm gonna go to the different implant workflow or a digital implant workflow in terms of different like in surgeries or single crowns. So I'm gonna walk you through it now. It says sometimes, I have another question here. It says, sometimes cement crowns rotate, and how do you handle that? I'm not sure how does that happen in terms if the abutment design was not designed, maybe the convergence, the total convergence of the abutments too tapered, maybe that will lead to no retention for the crown, you know, when you seat the crown. Or if it's a short abutment, then the crown will just rotate, and this is sometimes not a good sign. I may add grooves in the abutment anti-rotational, and then make sure that you have enough height and then enough taperness of the crown. And then there's another question: what's the advantage of screw cement retain implant over screw and cement retain? Screw cement retain, like scrementable crowns, over screw. Well, we went through that earlier. However, the screw cementable give you more variety of materials. So let's say you want to use an Emax crown or zirconia crown that is screwed, but you cannot, because you cannot cast it to the UCLA or Pernout abutment, if you know what I mean, that the one I showed before. So basically, the only way to do it is to mill an Emax crown or press an Emax crown with a hole in it and then cement it on an abutment outside the patient house. And then now you have a screw retain crown. the different advantage that like I said, you can use different variety of material. You don't have to be like doing only PFM for that. And then the retrievability over the cement retained, of course. And then in terms of screw retained by itself, the other advantage over that is that using different materials. I think that comes in my mind, that screw retained, usually you have to do it in a metal ceramic. And now screw cementable, you can do zirconia or Emax. I hope that answers. All right, so now before I go ahead and talk about the digital workflow and implant dentistry, let's go over a few digital terms. And this is ACP Glossary of digital dental terms. So what does analog workflow means and digital workflow means? So analog workflow is the process that we do using physical means, such as using the cast or using the wax up or using anything physical that is opposite to using digital technology. And then digital workflow is this similar to analog, but it's all digital formatting, okay, and using a CAD software. And then what is a fiducial marker? You probably have heard about that. It's an object that's used in the field in any imaging system. So using in any imaging system, you're gonna use an object that is reflecting, and then it's gonna appear in the computer. So this is also used as a point of reference or measure. So we can use that point to reference or to measure the distance in between. And then what does a scan body mean? Scan body is a scannable object that's used to translate the position of the implant. Instead of using an analog impression post, we can just use a scan body that will translate the position of the implant in the patient mouth to a digital file. So what does STL mean? It's a standard distillation language, and this file formatted, as this STL format is created by a 3D software system. Like when we intraoral scan the patient. And then what is the DICOM stands for? It stands for Digital Imaging and Communication in Medicine. So it's usually used, for handling, storing, printing any imaging or medical imaging system. And this referred to DICOM. So now we have STL, it's from 3D or intraoral cameras or 3D software system. The DICOM is usually from or CBCT. So let me walk you through a workflow for a single tooth implant. It's a fully digital workflow where we utilize an immediate implant placement and provisionalization. So patient presented with tooth number 7. She was actually referred from her restorative dentist saying the tooth number 7 or tooth number 1-2, the lateral incisor, is non-restorable. Please restore it with an implant and send it back for the crown. So here's a periapical radiograph of the tooth. It had debonded post and core, so I just temporarily cemented it back. And here's a closer look to the tooth. So when we look at or think about implant placement, immediately, such as in this scenario, always that paper comes to our mind that by Dr. Khan and his colleagues about immediate implant placement and provisionalization in the anterior zone. And then it gives us some ideas and organize our thought in terms of advantage and disadvantage of doing that, such as the advantage, of course, the main one is you have a shorter treatment time for the patient, and you hopefully preserving the soft tissue morphology and contour, and maybe you're gonna have, or probably you will have a better aesthetic results. And the disadvantage, of course, risk of mucosal recession, because if you don't handle it properly, you may lose that tissue, and now you will have adverse aesthetic results, and you will need someone who's skilled or supervised by someone who's skilled. And then here's some techniques that shows that that mentioned in the paper, that the immediate load may influence aesthetic results. And then if you take that tooth flapless and then place the implant without really raising a flap, is good, but also it needs a skilled clinician. So let me walk you through the digital workflow step by step. This is what I really did for this case, and most of the cases we get the data capturing means intraoral scan to get the STL file, and then imaging scan to get the DICOM files, and then we go ahead to plan the case, planning it by a software. So this is the second step, get the two scans together, and then we fabricate the surgical guide. And then finally, after placing the implant, we go ahead and do the digital impression for the final crown or another provisional, and then design it and then finalize it. So the first, as I said, we collected our data by capturing the CT or the DICOM. Here's the cross sections. It's very helpful to show the amount of buccal bone remaining and the thickness of the bone, and then the thickness of the native bone apical to the tooth, and how much bone do we have, and the angulation, of course, the sagittal angulation of the root. And then we capture the intraoral scan we capture the STL file, and this is what's taken. This is a patient mouth taken by intraoral scan by Trios. And here's the maxillary and mandibular arches, and here's the tooth of interest. And then once I have those data, I went to 3Shape software and I start collecting or planning the implant and the restoration. So the first thing the software asks you to, I don't know why this is not showing clear, but it will ask you to mark the tooth of interest, tooth number 7, and then go ahead. Next window will say, okay, bring me the CBCT or the DICOM file, and then you import it. And now you will merge the two files together because she has teeth, she's a dentate patient. We can easily mark references that this canine is this canine, and so on and so on. And now once it's merged, as you can see, the purple line is the patient teeth, and this is the CBCT. So this is STL and DICOM. And now go ahead and we confirm the alignment. And this is an important step because if it's not confirmed and you're not sure, then the surgical guide may not be seated correctly, or all your plan will be off. And here's the other window where you start planning. And here's the implant that I plan accordingly. So based on what you put like in a different implant size, this is a 3.5, I believe, implant. This is by Nobel. So based on what you choose, 3.5 or 4.1 or 4.3, and then how long is the implant? It's based on the bone you have, the angulation that you want. I'm shooting here for screw retain implant crown eventually. However, at the same time, you're not compromising and you're not causing a fenestration. So this is as a restoratively driven planning, because the patient crown that I had is and then the software will ask you to virtually extract the tooth. As you can see, you remove the tooth and you start drawing your surgical guide. As you can see here, we draw the lines, the surgical guide. You want to cover at least half of the teeth adjacent, and then make sure that it's going to be stable, hopefully. And then here's the surgical guide fabricated virtually now. And then I like to make windows here. So this will verify the seating of my guide on the teeth when I seat it. And then here's how the guide looked like before I print it out. And now it comes to designing my provisional crown so I can mill it and do an immediate loading that day. So we virtually extract. Of course, before we do that, we capture the tooth, or we can copy mirror the contralateral tooth that's shown here, and then we can play a little bit with the orientation and finalize it. And then the good, I was inspired by one of our co-resident that he had done this scenario before, where we're trying to capture the emergence profile, and this is by before we even do the surgery. We're trying to maintain it and preserve it by designing the temporary crown ahead of time and to capture it, and then we mill the temporary crown to have that emergence profile showing on it. And then here's our final design shown with a screw axis. And then when you think about it, before you load that crown, you will sometimes have a different or problems in the orientation. And then, you know, surgical or guided implant placement is not 100% really, it's going to be that accurate. So of course, it will have maybe a millimeter or two vertically and maybe laterally. So that crown may not be seated 100% on the abutment. Remember, we're not designing a shell. I'm designing the full crown with the emergence profile as well. So what we did here, we designed a positioning jig so we can position that crown easily, no matter what the implant position, the crown. I'm gonna add maybe a composite or acrylic to hold it together. And then we can also make a screw axis through that positioning jig. And this is how it looks before the printing. And now I send it out to the lab and then they print everything to me. They print the models, the soft tissue and silicon. And then here's the surgical guide. From design to print. And then here's the box that comes with the positioning jig, the milled temporary crown, and then the abutment that I requested with the screw. And you can see this is, we haven't done the surgery yet. We are mimicking the soft tissue profile, the emergence profile, and trying to preserve it for a better aesthetic result. And then here's the abutment that we get. Usually those abutments, because it's for single crowns, they will have like anti-rotational feature, but I remove it because this is not a final crown. This is a temporary crown, and temporary crown, I don't know where that abutment's gonna be. So temporary crown has to be freely 360 degree. I can see it normally with the positioning jig, if you know what I mean. And then here's the try-in and on the model. This is how it looks like. And now let's move to the surgical phase. Go ahead and extract the tooth as minimally invasive as possible using a power tome here. And then took the tooth out, placing the surgical guide, and then we place the implant through the surgical guide. As you can see, the windows that I told you, that it shows me that accurately that this guide is seated because there's no gaps in between the tooth surface and the guide. And here's the tooth placed after placing the implant. We place the abutment and then we place the tooth, we added a little composite and then we cure it. And here's, it shows after immediate placement. And then 3 months later, before I send her back to her restorative dentist to get her final prosthesis, I go ahead and I wanted to make another provisional just to show it to the patient. It looks better. And then also to document this is a fully digital approach. So in terms of, instead of making an analog impression, this is the scan body that I mentioned earlier. We attach the scan body to the implant and then we go ahead and scan it. And this will translate the implant position and the soft tissue contour to the software. Okay, so when we look at the ITI consensus, or what does the literature say about digital technology in terms of single implant digital impression, we'll find that the consensus statement, this was published 2017 or 18, by the latest ITI consensus meeting, that the accuracy of the intraoral scanners for single or adjacent implants is comparable to the conventional implant impression. So here's my workflow. We will scan, take it to the computer, we'll design, and then we will mend the prosthesis or the provisional crown, and then we insert it. And this is what we did. We scanned it, we designed a new temporary crown or a provisional crown, and then here is it after milling and inserting. So, and here's the soft tissue after a few weeks of healing after placing the new provisional implant crown. And here's the peri-implant tissue before I send it back to the restorative dentist. And here, I hope you appreciate the gingival tissue and the level of that compared to the adjacent teeth, high level, but we maintain it as much as we can. So Dr. Yuval, I'm not sure if we have time. If you want, I can go through another clinical scenario.
If we have any questions, we can take some questions and maybe
Sure.
have a part two. This is really good stuff. You know,
Thank you, sir.
The basics, the things that you kind of overlook when you do this stuff, and it's something we need to go back and chew on. I'll take a couple questions here, and I will have to bring Dr. Saad back.
Okay.
If you have any questions, please type it in, and if you want to speak, any of the panelists have anything to say? Doctor, I have my favorite go-to, Dr. El Brashi, are you there?
Okay.
Dr. Sam? Okay, Dr. Sam is here. So if you have any questions, please type it in. Yes, Dr. Sam says excellent.
Yes, Uvo, sorry.
Yes, go ahead. From what you've seen, you know, what do you? I mean, you guys have done this several times over. What's coming?
Firstly, the quality of the photographs is fantastic. So thank you for that. And very clear workflow. I think the thing that stands out the most for me is doing these cases flaplessly and immediately temporizing preserves the soft tissue so well. And as he showed, when you make a second temporary and you make an ideal provisional, you've basically, you've made a copy of what the final emergence profile should be. And you've communicated that to the lab very well. So it's a really, really nicely done presentation. I've got really nothing to add to it except the quality of the photos is fantastic.
Thank you, sir. Appreciate it.
Dr. Saad, you know, we talked about you doing some a photography session. You know, I guess we have just added a third lecture for you. Once you have time, let me know, and we will bring you back in. You know, we're trying to do a program for the students, an all-African dental students meet on August 15th. So just a short tidbits just to inspire dental students, you know, to go for excellence. And I know that dental photography is not something that is currently being taught in most schools. If I'm wrong, please somebody correct me. I don't know if you guys take any pictures at all. I know we take pictures of our full care case in our final year cases, but photography is not something we do regularly, and it's something that we want to encourage. So during on August 15th, a dental student is going to win a camera. You know, so for as many as come in, you know, if you show interest in wanting to learn about it and you do the post test, somebody's going to go home with a DSLR camera. So that's, well, thank you so much. I know no questions are coming in, and we also have Dr. Diogo from Ohio State here, and we're going to continue. Thank you so much, Dr. Saad. I'm really looking forward to having you back.
Appreciate it.
Okay, then. Take care.
Thank you. So I'm going to stop sharing, right?
All right, yes, go ahead.
Or you can do that for me.
All right, so we're going to...
Holding Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact facilitator